Okay, so to get started, I think we'll start with the recording. So we will be recording the session and we'll make that recording available to everyone a few weeks after. For those who aren't able to make it or would like to kind of go back and hear some of the panelists again. So to get started, okay, I think that's started. So to welcome you, it's my honor really to welcome you and to serve as today's moderator for Cal-IHEA's webinar on innovative strategies to diversify California's health workforce. Next slide. So my name is Denise Payan, and I'm an associate professor at UC Irvine's program in public health, and I'm also the director of Cal-IHEA, or the California Initiative for Health Equity and Action. We are a statewide research and policy center that supports the translation of research evidence into state health policy and practice to improve health equity in California. And we're really grateful. This effort was spearheaded and headquartered at UC Berkeley under Dr. Hector Rodriguez's efforts previously. And so in 2023, Cal-IHEA moved to UC Irvine, where I now serve as the faculty director. We're really grateful to have a project analyst, Rose Rees, and several graduate students and faculty associates here at UC Irvine who are collaborating on the work, and we're really carrying out the core activities. And so our priority areas, we have 3 priority areas, which include building a workforce for health equity, collaborating with diverse stakeholders to narrow health disparities and inequalities, and translating research findings into state and local policy and practice. And so today's webinar really focuses on that first priority area. Next slide. And so as part of this effort, we're currently funded by the UC Office of the President's Multi-Campus Research Program and Initiatives Grant. And so this will go on through the end of next year. And so the specific aims for that grant actually are expanding our partnerships with UC Merced and UC Riverside, including Drs. Irene Yan, Erica Lloyd, and Andy Subika. Our broader goal is to build health equity and policy research capacity and infrastructure across the UC campus, particularly in campuses that have had less activity in these areas or less coordinated efforts in these areas. And also really exciting, UC Merced and UC Riverside are actually carrying out these local policy to research to policy projects. And so next year we hope to showcase and highlight how this work can be done at the local level and in collaboration with grassroots organizations. Next slide. So unfortunately today, Dr. Arambula was not able to make it to our session, but I briefly just want to mention and appreciate the efforts of his office. Basically, Dr. Arambula is one of the leading legislators who's been working in this space. I'll briefly mention he was elected in 2016 to represent the 31st Assembly District, which encompasses Fresno County and the San Joaquin Valley. He is the first Latino physician that was elected to the California State Assembly and is part of the Latino Legislative Caucus. And he proudly represents a district that includes most of the city of Fresno, along with rural cities like Fowler and Selma, and unincorporated communities in the county. And he has been one of the leading legislators in California in terms of advancing health workforce bills, trying to bridge the gap, particularly in the Central Valley, and increasing the diversity, but also shortages, addressing critical shortage gaps that exist in that area and throughout the state. And so we appreciate his efforts and that of his office, but unfortunately, due to an active session, he was not able to make it today. So we just want to acknowledge his efforts and those of others in this space. But with that, we will have a little bit more time for the panelists, and we will be moving to the panel session. Next slide. So a shortage of primary care physicians and specialists, a lack of racial ethnic diversity and representation, language concordance or interpretation issues, burnout and stress. Add to that the growing importance of building trust in our health workforce to combat misinformation and to advance public health efforts. So today we're really honored to convene 4 experts from various UC campuses who will describe the scope of the problem, different dimensions, and highlight innovative strategies across California to diversify the health workforce, including what can be done in terms of the diversity of leadership practice and training efforts that are much needed to address our quality, cost, and access issues. So in terms of housekeeping rules, please do not use the chat. Please use the Q&A box that's available. Feel free to add questions throughout the session, throughout the panelist presentations, but we'll hold that Q&A at the end of the all 4 panelist presentations. And so with that, we will start with Dr. Janet Coffman Dr. Coffman is the Co-Associate Director for Policy Programs at UCSF's Institute for Health Policy Studies and is also the co-director of the Master of Science in Health Policy and Law program. She is on the faculty for UCSF's Healthforce Center and also the Department of Family and Community Medicine. She is a leading expert on the scope of health workforce issues in California, having co-authored multiple publications on the healthcare workforce in California and the US. And today she will kick off the panel with a presentation on increasing the racial ethnic diversity of California's health workforce. Dr. Coffman, thank you so much for being here today.
Yes, thank you very much, Dr. Payan. It's a pleasure to be with all of you today and to be part of this panel. I have been, working on health workforce issues in California for over 25 years, and racial ethnic diversity, I think, is one of our critical issues. So I was delighted to be invited to give this presentation, which I think hopefully sets, sort of the does the groundwork, kind of level sets all of us for the presentations by the other panelists. I'm going to be sort of a 30,000-foot view, and they're going to then go more in depth on particular initiatives. And also just want to maybe, as I start, recognize my positionality as a white, cisgendered, highly educated person, and recognize that, I myself personally, come from maybe a different position than many of the folks whose needs we're going to talk about today, but still, very much someone committed to increasing the diversity of our health workforce so that we can meet the needs of every Californian for health. Next slide, please. So we in California, and indeed we in the nation, need a health workforce that's ready to improve access outcomes and reduce costs. But we're not quite there. What we see when we look out in the healthcare landscape is increasing demand for health services, particularly behavioral health services. We see high rates of turnover in many healthcare occupations, particularly those folks who work in, say, in long-term care. We also see shortages of health workers in some locations and professions. And Dr. Payan referenced Dr. Arambula's district in the San Joaquin Valley. And indeed, the San Joaquin Valley has some of the most dire shortages of healthcare workforce in the state, as well as the Inland Empire. And we see these shortages often among primary care physicians, increasingly among behavioral health professionals, and among registered nurses from time to time. And we see wide variation in racial ethnic diversity across occupations in the health sector. Next slide. And I put this slide out here to just remind us that California's population is more racially, ethnically diverse than ever. And so diversity in the workforce, in my view, is an imperative in California because Californians are diverse. So these are data from the California Department of Finance from 1970 to 2020 on the racial ethnic composition of the state's population. And what I want to first call your attention to is sort of the turquoisey green color, and that's the Latino X population. So folks who are Latino X were about 12% of California's population in 1970, rising to 40% of the population in 2020, now the largest racial ethnic group. And then if we look at the other kind of pew screen, we see that Asian Pacific Islanders, 3% of the population of the state in 1970, 15% in 2020. So big growth there. Not so much change in the Black population, but still a very important part of the population in California. Next slide. And this slide is just to remind us of the wide array of occupations there are in the healthcare sector. Everything from physicians who require 4 years of graduate education, plus at least 3 years of residency, on at the other end of the spectrum, home and personal care aides who really only require a small amount of education post high school. And I think we talk a lot about physicians, and physicians are tremendously important, but I think it's also really important to remember that there's a large part of this healthcare workforce that is neither a physician nor a nurse, that they work in a wide range of occupations. And this will become important as we move to the next slide. And you don't explain why it is important to increase number of professionals from underrepresented racial ethnic groups. Why does this matter? Well, one possible reason it matters is just our diverse population. But also there's a large and growing body of literature that says that racial ethnic concordance between physicians and patients improves communication and improves health outcomes. And communication is always important. But if we think about the chronic conditions that affect many of us in California, and in some cases such as diabetes, are more highly prevalent, say, in the Latinx population than others, that communication about how to manage one's diabetes, let's say, to reduce the risk of complications, to manage risk factors, and how important that communication is, and how tied that good communication is to health outcomes. There's also a large body of evidence that Black and Latinx physicians are more likely to care for underserved persons, more likely to work in, say, communities with high numbers of Black or Latinx people in the population, more likely to work in, let's say, safety net hospitals or federally qualified health centers, those settings that predominantly serve people who are uninsured or on Medicaid. And so getting back to why did I call attention to the wide range of occupations in healthcare? Well, as you see, we have a bit of a tale of two workforces in healthcare. And so let's just look on the Latinx side. If we look at our California population, about 40% Latinx in 2020, we look at towards the top of the table, dental assistants, pharmacy technicians. These are occupations where folks need maybe at most a year or two of education post high school to enter the workforce. And we see there, 50% of dental assistants, 41% of pharmacy technicians are Latinx. So pretty much on parity with the Latinx population in the state. But then let's go down towards the bottom of the table to dentists, pharmacists, physicians, all of which require a graduate degree. And in the case of physicians, must have at least additional 3 years of residency training to be eligible for board certification. There we see a different story. Only 9% of dentists Latinx, 8% of physicians, and pharmacists, sadly dead last at 3.8% being Latinx. So we really, have the situation in which for those occupations that don't require a lot of education post high school, pretty diverse, but the more education that's required post high school, the more poorly Latinx and Blacks are underrepresented, as are some Asian Pacific Islander subgroups. So next slide, please. So what drives this? Well, there are many drivers, but I think it really is fair to say that in large part, this is driven by racism at all levels, institutionalized, meaning the racism that affects who lives where and the quality of schools that are available to them, the sorts of jobs that are available to their parents and the impact on their income. Personally mediated racism, racist expectations about what folks who are Black, Latinx, or from certain other groups can and can't achieve academically and professionally. And internalized racism, what folks believe about themselves and their capabilities. Next slide. So I just want to share one particular data point from some research that I have done with colleagues at the Latinx Center for Excellence at UCSF. And this is a study we did to look at pre-health advising in California State University campuses, University of California, and select private institutions in California. And our bottom line is this, that there's limited access to pre-health advising, particularly in the CSUs. And the way to read this little chart here is that the person sitting at the table is a pre-health advisor. And the folks to the right of them are each one of those little people figures represents 1,000 graduates. And so you can see at Cal State universities that there's far more graduates, far more young people than there are in at UC and also particularly privates. And this is important because our CSUs are our most racial, ethnically diverse group of folks getting bachelor's degrees. Next slide, please. I need to speed it up. So recommendations, I'm not going to spend a lot of time here, but I think clearly, some things that, you know, we would hope the state would invest in, at least in a year where we've got a little better budget picture than we do this year, is programs that support people getting additional education. So healthcare workers who stay are a certified nursing assistant to get the education, say, to become an LVN, or for in-home support workers to get their their CNA certification, pre-health advising at undergraduate campuses, pipeline programs, and we have a number of these at the UC, particularly the programs in medical education. And just lastly, one thing that seems small but can make a difference is providing emergency funds to health profession students from disadvantaged and underrepresented backgrounds. Scholarships, very nice, very important, loan repayment, but also these emergency funds. So I'm going to stop there because, as you can see, I can talk about this far longer than my allotted time.
I think that speaks to your expertise. Thank you, Dr. Coffman. And you'll have her email here, as well as learning more about the resources at UCSF and the center, and more broadly in this space. UCSF has been one of the hubs developing health workforce publications and materials, including analyzing strategies to help address some of the issues that were mentioned. So thank you so much, Janet, for being here, for your expertise. I think you are one of the leading health workforce experts in the country, and certainly in California. Next, we will move to Dr. Alejandra Casillas. And so our second panelist is faculty at UCLA's David Geffen School of Medicine. She practices primary care and also teaches UCLA medical students and residents. She graduated from Harvard College and Harvard Medical School, then went on to complete her internal medicine and primary care residency training at UCSF. And she's really dedicated her career to addressing health inequities, both in her practice, but also her research. She focuses on improving medical care access for underserved and limited English speaking proficiency patients. So with that, I will also add that she is a leading telemedicine specialist, particularly patients with limited English proficiency. And so it really has a great sense of different types of access barriers, including structural barriers with lack of provider access, language concordance issues. So with that, I will hand it off to Dr. Casillas. Thank you for being here.
Thanks so much, Dr. Payan, and thanks for inviting me. It's such a pleasure to be with you here. You've been such an inspiration as well in the work that you've done. So thank you so much for having me here. And so I was asked to speak for a few minutes on the importance of a diverse physician workforce, particularly in my personal work with Latino students and trainees and first-generation college graduates in medicine. But I really just want to address the elephant in the room and call out that there's really no Band-Aid solution or one-dimensional approach that's going to fix hundreds of years of problems in our country. And we really need to think big. And this is all going to require systems change. So we can go to the next slide. I want to acknowledge the incredible team at UCLA that facilitates the work that we do. And also what we usually posit at the beginning of our talks, or a disclaimer of sorts, that we bring our personal biases based on our life experiences and commitments to this work in EDI. So for next slide, so what I'll say, my personal bias is also my personal motivation. I am a primary care physician, as mentioned, and a health services researcher, and I witness firsthand every day how my patients have suffered because they didn't have physicians that could adequately listen and take care of them. And as a researcher, I analyze the data on the health disparities that affect them. But more personally, I was born in Los Angeles. I'm the daughter of Mexican immigrants. I'm a first-generation low-income college graduate. My parents did not go past the 6th grade in their education. So all of this work is not abstract to me. It's not an academic exercise. I'm really here because I wanted to be the physician that my family didn't have because of social circumstances, and witness to the many traumatic healthcare and disparities that they experience that we all face. So up to this day, up to this week, I continue to get calls from cousins and uncles and extended families, many who don't speak English, trying to intervene as their family member as this cycle of classist and racist healthcare continues for all of us in our community. And as a faculty member, I work to develop the next generation of diverse physicians that can take care of all peoples and treat them with respect that they are entitled to. But I tell you that I've realized that my story continues to be repeatedly reflected back to me in the voices of my many students and trainees. So that's why I'm here, and that's my personal bias. So let's go to the next slide. So why is physician diversity important? We could really spend a whole day, a whole retreat, and some of the data was already cited, but we could spend many, many hours citing the data by researchers and policy reports that detail the impacts and benefits of a diverse physician workforce on society for all of us. But I figured in the next slide, we can just summarize a few key points. And yeah, Rosa, you can just, there you go. I think we have and then one more, I think, at the bottom there. I'm not going to go through all the mechanisms, but in terms of important points to mention, with a diverse physician workforce, we have broader perspectives and innovation. So there is a whole business case literature for this, citing that multifaceted teams bring better innovation to not just healthcare, but in all sorts of enterprises. Enhanced patient care and outcomes, and Dr. Coffman sort of cited some of that evidence. Reduction of health disparities through improved cultural competency, knowing, as cited before, that improved communication, trust, and patient satisfaction leads to better diagnosis, treatment, and adherence. And then also advocacy of physicians for these patients. And also enhanced healthcare access, as was mentioned, more likely to work in underserved areas. Go to the next slide. And then the last few points also citing the importance of improved education and training for all physicians, knowing that diversity of faculty and students enriches the educational experience for all, even for those who come from traditionally majority backgrounds, right? Also the importance of reflecting the population, which enhances the perceived legitimacy and trustworthiness of the healthcare system, promoting a culture of dignity. And lastly, but not least, mitigating bias and stereotyping, so that when we have a visibly diverse physician workforce, for those physicians that may come from majority populations, when they see diverse physicians, that actually mitigates their perceptions about underrepresented groups and can lead to more equitable treatment of patients as well. You can go to the next slide. But what do I mean by diversity in this context? So we could talk about diversity of many identities, right? But I'm really talking about, and I think we're all talking about, building diversity that is equitable and inclusive, and being very intentional about that, intentional about centering at the margins. So this is a wheel of power and privilege that was developed by Sylvia Duckworth, and it basically shows you the different important categories of identities in U.S. society: citizenship, skin color, formal education, ability. I'm not going to name them all. And at the center of the wheel, you see versions of those identities that have held the most power in our society, right? And so we're thinking about building systems where we start to include those at the margins and put them at the center. And that's what I mean by intentional diversity in this context. We can go to the next slide. We are being intentional about building a diverse physician workforce that aspires to be equitable and inclusive. And by equitable, I mean a diverse physician workforce that will repair injustices and disparities in healthcare and health, so that we have healthcare access and outcomes that are more equitable and inclusive, so that we represent communities in these physicians that are underrepresented in medicine. And I mean underrepresented when compared to the general population, and also focusing on identities that are disproportionately impacted when it comes to healthcare disparities. So we can go to the next slide. So some identities that I'm calling out in this process of equitable and inclusive physician workforce diversity, I'm specifically calling out racial and ethnic minority and other marginalized groups, and those that are linguistically diverse, because these are groups that we know have been historically and contemporarily disproportionately affected by healthcare disparities. And then I'm also specifically calling out first-generation low-income college graduates and those from lower socioeconomic statuses, because these are traditionally the groups that have been left out of the academy or of formal education in general. We can go to the next slide. So just to speak to some of these points, and I don't want to berate this because I think a version of this slide basically has already been presented, but here you can see different racial ethnic minority groups and see the mismatch between their representation between the national population percentage and active physicians. And I would go on to say that there's probably a greater mismatch when you look at the state of California alone. And then what we should also note is that amongst these populations, these racial ethnic minority populations they are also overrepresented when it comes to care access problems and health disparities. And then we see sort of the match of these two different columns with the knowledge that 56% of physicians identify as white non-Hispanic, compared to 59% of the population being white non-Hispanic in the United States. So very much closely matched compared to the mismatch that we have here. And obviously calling out the Latino example in California, where we may have some areas that are 70 and 90% Latino Spanish-speaking populations and less than 6% Latinos making up the workforce, and maybe even lower in some of those areas as well. So just to sort of speak to some of these points as well, this is a paper that is from Nature highlighting a 2020 survey of over 7,000 US tenure track faculty. And the study showed that faculty are up to 25 times more likely to have a parent with a PhD compared to the general population. And this rate nearly doubled at prestigious universities. And 90% of all faculty surveyed had a parent with at least a college degree. So these results really suggest that the professoriate, the academy, those in formal education has remained disproportionately reflective of the socioeconomically privileged. And then just to the next slide, in terms of income in medical students, we know that for the past 3 decades, more than 75% of medical students came from families in the top 2 quintiles for income in the US population, while only 5% came from homes in the lowest income quintile. And basically, this is a report from the AAMC that looks at the years between 2007 and 2017, showing that not much has changed from the data that we had for the last 3 decades when it comes to income representation of medical students in the United States. And we can go to the next slide. So I want to sort of really call out the fact that addressing barriers and challenges is really going to require us to think big to climb this mountain. It's going to require structure changes. Next slide. And so I'm going to take us through a little bit of a thought exercise in terms of what it is to achieve success here in the United States. So America has a very powerful narrative that it's a true meritocracy, and equality imagines a world that is fair. So, we hold these truths to be self-evident, that all men and women are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. And here you have 3 groups of people trying to climb that ladder to success. Go to the next slide. But the world isn't equal, and America is not a meritocracy, because if we look at these different groups of people climbing that ladder, on the left, just sort of taking some extreme examples, high SES white population, in the middle, maybe a low SES white population, a high SES minority population, and at the very extreme, at the right, low and mid SES minority, we see that there are different layers of levels that help certain people have a much shorter ladder, and then certain holes that are being dug that make the ladder even longer and harder to climb, right? And so just a reminder that the 1964 Civil Rights Act did not fill in the hole. It just gave federal support to stop digging the hole, right? But we never filled it. Go on to the next slide. And 3, the ladder is riddled with bias and systemic racism. So even when you're trying to climb that ladder for certain groups of people, it's completely broken, given underfunded schools, positive remediation, under and uninsured, implicit bias. And most of our URIM students actually fall off the ladder very early on because it's very, very difficult to advance. And our pipeline programs usually begin at the top of that ladder. So we lose a lot of people down that hole because we are just not getting to them in time. So diversity only places more people from marginalized groups into an unequal pathway. Next slide. So true equity is going to actually require a lot more change. it's going to necessitate that we redirect resources to the pathways with greatest need to fix barriers and intentionally provide support. And justice closes the holes and starts to add some boxes and levels so that the ladder gets shorter. And so I love these figures that were created by Dr. Keith Norris and Dr. Seaman as part of our UCLA team that really shows how intentional we have to be about structure changes to really make a dent in the system. Next slide. The next slide shows some important policy recommendations that were presented in a paper in JAMA by three of my colleagues who are Black male physicians, some of the few Black male physicians in the United States, talking about intentional policy recommendations to improve physician representation in medical school of folks from diverse backgrounds. Next slide. And so I would really urge us to not iterate on what's been done in the past, but to really tell a different version of the same story, but to really change the story and to move towards changing structures which get us closer to liberation. Okay, thank you so much.
Thank you so much, Dr. Casillas, for sharing. I think that an additional perspective of the dimension of the issues, thinking about higher education in the next generation, and just mentioning the collaborative efforts that are going on and the importance of working together and collaborating in a structured way, right, for these efforts. And Dr. Casillas is also really well known as a mentor to the next generation, a deep mentor, but is also somebody who is training the next generation. So I welcome questions as well. Please start answering those questions. We will have time at the end to answer those. So thank you so much. Now we are moving to our next panelist, Dr. Billimek, who is faculty at UC Irvine in the Department of Family Medicine. He is also the co-director of the program in medical education for the Latino community, or the Prime LC track. And he's leading initiatives that support bridging the gap between research dissemination and practice. His work leading the HELIOS lab focuses on addressing the underlying root causes that drive health disparities. And he's also actively engaged in collaboration with creating innovative strategies to diversify the health workforce and to provide more responsive care. So with that, I'm really excited to hear more about this new effort. I think ending its first year, right, Dr. Billimek? So really excited to hand it off to hear more about this work.
Thanks so much, and what a pleasure to be part of this panel and to really hear from our first speakers there. Really just, I think, very clearly describe the depth and persistence of inequity in our health system, and the level of effort it'll take to really repair what is a very broken system. I'm going to speak a little bit about an effort at UC Irvine that we're doing, building on some of the successes of the UC Prime programs that have already been mentioned. We call it UC Prime Pre-Health Pathways. And we can go to the next slide. Again, we've spoken quite a bit about the lack of representation in the health professions, particularly at the doctoral level. So we can go to the next slide. And across the state of California, we have the UC programs in medical education. These are mission-based programs in schools of medicine where they each sort of have a different focus. The first UC Prime program started at UC Irvine in 2004. Over the next 2 decades, we've seen Prime programs rise at an array of UC campuses. Dr. Arambula, the state representative that was mentioned earlier, has been a wonderful advocate of the expansion and support of Prime. At UC Irvine, we added a new Prime program called Prime Lead ABC with a focus on African, Black, and Caribbean communities. And what we've learned is that we are doing a lot of work at the top of the ladder, and I think we've seen some success. And we see opportunities where we can really leverage some of the strengths within our undergraduate campus to start working a little bit earlier in the journey of students that are interested in pursuing the health profession. So next slide. In the UC Prime programs, I'll start on the right side first, is that some things that have done really well at UCI, some strengths, is that we've had a direct link. There's a number of deficits, I would say, in schools of medicine with respect to supporting a very inclusive environment and supporting education about the breadth of upstream factors that influence health and how we can be best responsive to opportunities to support the health of disenfranchised communities. And one way that our prime programs have really helped bridge that is by reaching to our undergraduate campus, where we have very robust ethics studies departments, public health, other schools and programs on the campus that really provide that complementary, educational and knowledge base resources. We employ a cohort model where students, of course, are in our prime programs are very are involved in the entire medical school class, but there's some activities that really focus on building a close-knit cohort of participants. And one thing that's a beautiful thing about the prime programs, if I ever see an alum out in the community, first thing I'll ask them is, hey, show me the group text, and they'll pull up, and one of the last 10 texts on their phone is the group text for their graduating classmates, the 12 or so students that were in their prime cohort. And it's a very tight relationship that's preserved over time. Just like Dr. Casillas said, it's so important to be focused on systemic change. I think that the prime programs really focus on leadership development, where prime graduates become equipped to lead within their institutions and also in the broader community in advocacy and other leadership roles. And that there's significant, I don't know if they're yet adequate, but at least significant funding and supportive resources that help our students succeed in medicine. And at the undergraduate campus, we felt like that there was an opportunity to really build the bridge, kind of open the lanes of the bridge in the other direction, to really help connect our undergraduate students to the School of Medicine, which previously has been almost like another planet. It's been very challenging for undergraduates, especially our first-gen undergrads that maybe don't have a lot of prior connections in the healthcare system, to have opportunities to gain clinical experiences or to get to know role models and mentors in the School of Medicine and in the other health sciences like nursing, pharmacy, et cetera. Our pre-health advising, I think, again, Dr. Coffman's slide really showed how under-resourced we are in pre-health advising. And at UCI, all of our pre-health advising existed in the biological sciences major. Many of our students interested in the health professions aren't in that major and don't need to be in that major to pursue those careers. One place we have a lot of strength is our research infrastructure on the campus, and yet we see that first generation and minoritized students are less likely to participate in research. And research is a wonderful way to kind of have a deeper and richer experience on the undergraduate campus, and also to be prepared for the health professions. And like I said, we wanted to increase exposure to clinical experiences and mentors. So what we've done on the next slide is start to, a number of the faculty, both from the main campus, really led by our PI, Belinda Campos, in the Chicano Latino Studies Department, as well as faculty from the School of Medicine, both of our prime programs, came together to try to design, in partnership with students and other stakeholders, what could this undergraduate program look like? Next slide. And we developed something called the Prime Pre-Health Pathways Program, applied for funding from HCI and the Health Professions Pathways Program, and were funded to begin our work. Next slide. With our mission to cultivate a diverse and inclusive community of future healthcare leaders that are equipped with knowledge, support, and opportunities to excel in the health professions. So next slide. The program really consists of three major pillars. Our leaders are Lena Joku, our program director, who I see is in the audience today, as well as two full-time coordinators that are funded by the grant to do work in outreach and inreach, evaluation and advocacy. So just understanding the impacts of what we're doing and how can we advocate for appropriate resources to continue and expand this work. In the middle, we have something we call our cohort program, which is modeled a little bit after some things we're doing in the prime programs. The next slide, please. Outreach and inreach, we spend time visiting, there's quite a beautiful array of pre-health conferences, networks like Mi Mentor and other big networks that support students or people on the journey to the health professions. So we participate in those kinds of events and activities. We've also established InReach, where we're trying to reach into the existing pre-health student clubs on the campus. We started a course called Introduction to the Health Professions that lower division students can enroll in and just start learning about where some of the opportunities might be to advance in these professions. Next slide, please. Our cohort program begins with an intensive summer program. So it's a 10-week summer program where we have a weekly curriculum that focuses on professional development, research, leadership, becoming connected to clinical service learning opportunities. And we provide stipends for the scholars themselves, the undergraduates, as well as medical student and graduate students and nursing student mentors that are near-peer mentors for those undergraduates, and fellows who are recent bachelor's degree recipients that are in their gap years or growth years on their way to their journey. We continue the program throughout the academic year following the intensive experience once the cohort is formed, have additional opportunities for service, leadership development, and even social opportunities to strengthen that cohort. Next slide, please. Part of the process is we help place people within different research labs that have a health equity focus and also have connections to community and clinical partners where learners can start doing research that connects them not only to the topics that relate to health, but even the environments where healthcare and health services are delivered. Next slide, please. As I mentioned, our cohorts consist of so we have about 25 undergraduate scholars per year, 6 fellows who are post-bachelor students per year, and 6 medical student and graduate student mentors that help support each other. Maybe I can take more about that during the Q&A period. Let's take the next slide. And just some takeaways, I'll say that cascading mentorship has been really important. Having near peers to support our learners in the process has been really valuable, both to the mentee, but also to the mentor. Seeing how far you've come is a beautiful way to kind of reset your confidence as you advance to the next level. The research experience has been valuable for professional development. Clinical placements have taken time. I think we've had a little bit of growing pains figuring out how to really get students plugged into clinical learning opportunities, but that's growing and improving. Our fellows and mentors are wonderful creators within the program. They develop some of our best subject matter that we deliver to students. And there's already in the early stages really deep interest from university leadership and philanthropy to kind of support and advance this work. And so I think this is a wonderful place where we can help become a focal center to invite additional investment to achieve some of these objectives. So thanks for this chance to introduce our program. I would love to hear from anyone who's interested in discussing it further, and I'm welcoming questions as we get to the end of our panel. So thank you.
Thank you so much, Dr. Billimek. And our Q&A is now open. It was closed until a couple of minutes ago. So please start putting those questions in as we move to our 4th panelist. And I'll just add 2 of our Cal-IHEA undergraduate health equity scholars were UC3P scholars, and it was just a joy to integrate and work with these students this year. So I'll briefly talk about that after the 4th panelist. So thank you so much, John, for your remarks. Our 4th and final panelist is Dr. Rosa Manzo. It's a pleasure to have her here. She's a project scientist at the University of California, Merced, and her expertise really explores strategies to promote health equity through community-engaged research. She has been spearheading community-engaged strategies to shape medical education programs and initiatives in the Central Valley, and she just consistently demonstrated this deep understanding of the importance of multi-level approaches to address health disparities and regional health workforce issues. And it's really critical in the region that she's in particularly, and I was previously at UC Merced for about 5 years and had the pleasure of seeing some of this work. But just last month, the California Healthcare Foundation Central Valley Survey reported a majority of respondents in the Central Valley that were surveyed reporting that they do not have sufficient primary care providers or specialists, and a very high percentage are delaying their care due to cost and access issues. And that's in line with this area has some of the most severe shortages of providers and specialists, particularly in behavioral health. So it's just a pleasure to have Dr. Manzo here to talk about the work that she's been doing. So with that, I will hand it off.
Thank you, Denise. It's a great honor to be here with everyone today. And thank you to my colleagues who have presented and provided very good information in terms of the needs of having a very diverse healthcare workforce in our region for more equitable and inclusive health to provide for the health needs of our state. Specifically, as Denise mentioned, my work centers around the community engaged strategies for health research, but also medical education programs in the region. We have a high need in the region. And so some of the things that I'm going to be highlighting today is the efforts at UC Merced to find innovative solutions to healthcare workforce needs, specifically looking at how can we think about innovative strategies for healthcare beyond the four walls of a clinic, right? Because we know that health occurs in a system where we think about the social determinants of health and how that impacts, and can we bring that into really developing the next generation of healthcare providers. So next slide. So I'm going to be really talking about my work with community-based activities at UC Merced, specifically focusing on the development and implementation of community-based interventions to promote health equity with attention to cultural context and processes. So this is really focused on how do we integrate community health workers or promotoras, and I'm going to use the term interchangeably, into health research to really promote health equity that takes a look at that really incorporates that cultural context and processes of the population. And then the second focus that I'm going to discuss is aligned with what everybody else has talked about, medical education and really fostering the next generation of doctors who can provide culturally concordance care in the state and specifically in the region at UC Merced. So next slide, please. So promotoras, for many of you who may not have heard the word promotoras or are not familiar with the term, these are community members who work with hard to reach, vulnerable, low-income, underserved communities. They are trusted members of their local communities. They serve as cultural brokers between health professionals and social services professionals and researchers. And so recently at UC Merced, over the last 5 years, I've been working under the Translational Research Center and now the Center for Health Equity to really establish a network of promotoras in the region where we are integrating their expertise in the development and implementation and in health-related research. So that really takes in the approach of working with the community, building on the community's assets of knowledge as we design health-related research projects. Next slide. So one of the initial projects that I led was the Promotora and Community-Based Education project that focused around asthma management and education. And some of the words in this image may be a little small, but to give you an idea of this model that we worked on in the last 3 years was that we wanted to take the promotoras really and center them as health providers, specifically with the focus on asthma management and education. And so the promotoras went through community-based health professional training around asthma management and education. They received certification. They also had research and program evaluation training through UC Merced. So a unique component of UC Merced is that we have a mechanism where we're able to make them affiliates of the university, meaning they get a university email address, they get a university ID card, and also access to software library facilities. And as part of that, they are able to become part of our IRBs. So that means that they can now work as direct research personnel on research projects. And so that allows them to be fully integrated into our research processes and the way that they fully partner with us from the design to the piloting to the data collection to the data dissemination of our research projects. So this was the initial project that I worked on and really made sure that we collected data, that there was data on that bi-directional support from the institution and the federally qualified health center to make sure that we develop a strong community academic partnership for this program. So next slide. So as I mentioned, the promotoras receive a certificate of completion in the asthma education. They were training other promotoras as well. So this was more of a train-the-trainer model where they trained other promotoras, not only on the asthma education, but also on the research. And we really established a bi-directional training and research support where we brought in other institutions within the region because there was the need for additional training for the promotoras. So for example, as the promotoras were delivering the health education that center around asthma management and control, they indicated there was the need for additional training, and they wanted to hear more from clinicians of examples of silent chest asthma and what is that clinical representation and how can they explain that to the community. So we brought in residents from Valley Children's Hospital to provide seminars around pediatric asthma for the promotoras, and then the promotoras would go back and provide that education to the community. Another component of this bi-directional training and resource support that we established under UC Merced was our collaboration with the UCSF School of Medicine, and I'll talk a little bit more about how that has evolved, but this was during the COVID pandemic, right around, it was right in 2020 and 2021, where the first-year medical students could not go out and do shadowing opportunities. So we had to develop an innovative strategy to provide training over the summer to the medical students, and we had the medical students come and shadow the promotoras the same way that they would shadow a physician in the clinic. But of course, because of COVID, this was over Zoom. So the way it was set up was that we had the promotoras delivering the asthma management and control intervention. And then we had the medical student assisting the promotora and shadowing the promotora. So they would assist the promotora in their preparation for the health education session. They would find additional resources to provide to the asthma patients. And all this was done over Zoom. And the health education sessions were done in Spanish. So we had to bring in UC Merced undergraduate students, who most of them were pre-health, pre-med students that were trained as translators, and they were doing simultaneous translation between the promotora and the medical student and the patient. So we had a whole setup over Zoom where we developed this clinical virtual rotation for medical students, but at the same time, it presented the opportunity for undergraduate students to come in and serve as interpreters during this time, and also learn from the promotoras and the medical students. Next slide. And so another element that came out of this was really thinking about how do we integrate the community health workers into our research process. And so my team and I worked in developing this community-driven research framework that really highlights how we could work with communities to establish community university partners, collaborations for research and action that builds in the knowledge that's already in the community. So bringing in the community members in this process to really think about how we could bi-directionally learn from each other, and that we develop interventions that are embedded within the local context and address the needs of the local population. So next slide. And this work has evolved into the Center for Health Equity that is funded by Genentech. And we are now working with 3 health systems in the San Joaquin Valley, where we are now training the community health workers and promotoras in these 3 health systems. But we're also exploring how the promotora community health worker model can foster trust in the healthcare system, and how they can also serve as providing health services to underserved populations and bridge that gap in a region that has a high need for healthcare professionals. Next slide. And so the last piece that I wanted to elaborate on is that development of community engaged initiatives to improve education opportunities and culturally relevant curriculum for training healthcare professionals. So more recently, my work, next slide, please, has informed the work of the PRIME program, and my colleagues have already described the PRIME program at the University of California. And so at UC Merced, we are currently consider a regional campus where we are collaborating with UCSF and UCSF Fresno in the development of the BSMD program, which is already in place. We just admitted it at our second cohort. And next slide. And we just had our groundbreaking ceremony for a brand new medical education building. And so by 2027, we'll have the first class of medical students at UC Merced. And the unique component of this curriculum is that we are really embedding this community engaged practice, where we are currently establishing partnerships in the community and centering the community health worker model and the promotora model to develop the curriculum and activities for current medical students, but also for the BSMD students who have just started the program. So thank you very much, everyone, for the opportunity to present some of the initiatives that we have going on at UC Merced.
Thank you so much, Dr. Manzo. And now we have a couple more minutes. Next slide, I just want to say thank you so much to the panelists for their work and contributions and for being here today. At Cal-IHEA, we believe in doing the work that you are supporting. So in our small way, this is one of our efforts, a Health Equity Scholars Program, where we take students, undergraduate students from 4 of the UC campuses to this health policy conference in Sacramento. So we're able to take students from 4 of these campuses, including Rose, and basically it was a really great experience. I think we also need to bring these opportunities earlier so students can see themselves as leaders. And as I said, the UC Irvine students were actually part of the UC 3P program. So there's a lot of opportunity for synergy and overlap and collaboration. Next slide. So just briefly, I think we have a couple of questions that came in, but we're going to ask just one question quickly to the panelists that we had kind of pre-developed, and we're going to try to save the questions that were put in, we're going to try to get back to and share as part of our briefing documents. I just wanted to ask, like, how can we effectively tackle burnout and short staffing and thinking about lower job satisfaction among healthcare professionals, especially from those in underrepresented backgrounds? So I'm going to limit everyone to just a brief 30-second kind of comment if you have anything to say on this specific issue before we close.
So, well, Denise, I'll start, and I would say the key thing is addressing the structural aspects of work in the healthcare sector that affect people. I mean, it's not to say that stress reduction is important at the individual level, absolutely. But what's really, I think the evidence is increasingly showing us what's really driving burnout and moral injury is the structure of work. So thinking at the structural level, not just the personal level.
I'll second that, Dr. Coffman, and just say that I think probably an important mechanism is, at least on the primary care side of things, is to start to see a little bit more of workers organizing, both across medicine, but across nursing and all members of the care team, to really speak to some of those structural issues. Certainly, wellness activities and stress management are there's some value to them, but fully agree that there needs to be some organization of workers to insist upon changes to the work environment.
You know, if the workload is unsustainable, the most stress reduction is going to do is help you get through it. It's not going to ultimately fix what's driving the problem.
Yes, I would agree with that. As noted and stated, many diverse physicians go back and work in underserved areas, predominantly FQHCs. I work in one of them as well. And it's not the complicated patients or the medical issues that cause burnout or cause issues in terms of mental health for our physician workforce doing that work. It's the workflows, it's the under-resourced settings. And so as much as possible, the investments in these community health centers and improving workflows and multidisciplinary teams to help physicians and other providers do the work of taking care of those patients, I would say it goes a long way in terms of the preventing burnout of these populations.
I also agree with my colleagues, and one of the things that I want to highlight is that a lot of the physicians, or especially those that are coming from underrepresented backgrounds, that graphic that Dr. Casillas presented with the hole is they're digging themselves out of the hole. right? So they're already like fighting a system. So by the time they get to their practice, they're tired, right? There's already that burnout component there. So I think, for those of us who are at institutions, really thinking about how can we facilitate that pathway so that they don't have to struggle that much as they're digging themselves out of the hole and they're already burned out by the time they get to their practice, So I think it's really thinking about mentorship components, facilitating those pathways for the next generation of healthcare providers.
Thank you. I wish we had another hour to talk about this, but we encourage everyone. We consistently had over 100 people during this webinar, which is incredible.
Wow.
There's so much interest and engagement. Please continue these conversations and reach out to our amazing panelists at these different institutions. We also invite you to see prior Cal-IHEA evidence briefings, including 2020 briefings on efforts to expand California's behavioral health workforce in response to the pandemic, and also efforts to address the Latino physician shortage. And so thank you so much to our panelists, to our attendees, to Rose and to Maddie and the UCI Public Health Communications team who really helped to plan and put this event together. We are at time, a minute over, but please subscribe to our newsletter. We will be sending out information about the recording and also the accompanying briefing document that goes with this. So thank you so much and just have a great day. And please continue these conversations and efforts.